Good afternoon, everyone. It's Dr. McQuillan from Berkshire Menopause Clinic. Now, we are on our third part about endometriosis, and this time specifically about menopause and in particular HRT. So, let's talk about the treatments and whether or not HRT is suitable. The first thing to say about any menopause treatment with or without endometriosis is that care should be individualized based on your particular case, based on what your symptoms are, based on if you've got any particular medical issues or conditions, and of course, if you've got any risk factors such as having a risk of breast cancer. Okay, so we need to really individualize that care with your menopause. And even with those with endometriosis, I still always try and go through everything, and that includes not only whether or not HRT is suitable, but whether firstly keeping a symptom diary, keeping a trigger diary, and keeping a diary of things that help improve that. Can you improve things in your lifestyle? We've already covered all of this in the general treatment, so please do watch the video about endometriosis and management. So what lifestyle factors, how can we reduce that inflammation as well? Non-hormonal medications, because not everybody wants HRT and not everybody is suitable to have HRT. Remember, we've also said, not only are we talking about endometriosis here, but have you got any other medical risk factors? So not everybody can take HRT, so non-hormonal medications. Then when we talk about HRT or hormones, some people may benefit from contraception. So we've already talked about management of endometriosis, and part of that we talked about things like the combined contraceptive pill, the progestogen types of hormones. Now, if you're younger and you're not going through menopause, but you're getting perimenopausal symptoms, you might actually benefit from contraception as a hormonal treatment because one, you may need contraception, but also it may help manage if some of your symptoms are things like heavy, painful periods. If that is all your symptoms, you may well benefit from something like a contraceptive pill or one of the other hormonal contraceptions as well. And then, of course, there's HRT, and that's probably something that everyone's eager to know about, and we're going to go through that in detail now. So the burning question is, can you have HRT when you've got endometriosis? And the answer is absolutely yes, but it needs to be balanced. And it's really important we understand about HRT and why it is important to balance it. So if I take my model here, this is our womb, in particular our womb lining, the endometrium. These are our ovaries, this is the cervix, this is the vagina. When we have endometriosis, not only is our womb lining being shed, but there are endometrial-like deposits in other areas of the body, be it in the ovaries, be it in the cervix, the vagina, in the pelvis area, around the bowel, the bladder, and maybe further ahead, like the lungs. Now, why is it important we balance it correctly? Because with endometriosis, what it's thought of is that there's estrogen can flare that up. So if we're giving HRT, that can flare up endometrial deposits, not only in the womb, but in other areas of the body. So it's really important we understand that as to what types of HRT we can give. So when we talk about HRT, I try and simplify it. It's very complex when we look at endometriosis, and that's why if you're listening to this video, please know that when we're talking about you as an individual, we're not going to go through every single scenario. We will tailor it specifically to you, but I'm just covering everything. So it is quite complex, so just keep that in mind. So when we talk about types of HRT, this depends on the extent of the disease, if you still have your womb, if you still have your ovaries. It depends on your menopause status, whether or not you're in menopause. And it depends on whether your fertility status as well. Are you still trying to get pregnant? These can all really influence the type of HRT. So if we start with the extent of disease. So if we have endometriosis that is beyond the womb, everyone who has endometriosis beyond the womb, who has had their womb taken out, would still need combined HRT. So let me clarify that. If you've got your womb, you will always have combined HRT. Estrogen tends to help with our symptoms. anyone with a womb, we give progesterone to protect our womb lining, because if we have estrogen alone, it can potentially thicken our womb lining and put us at risk of womb cancer. So that's if you've got a womb. Now, even if you don't have a womb, I've just said there could be endometrial, your womb lining deposits in other areas of the body. So if we gave estrogen alone, that has potential to thicken those areas of the body, of the endometrial tissue, and potentially flare up endometriosis in those areas, as well as thicken those lining and put us at risk of cancer of those womb-like deposits. So that is why anyone with a womb or without a womb with extensive endometriosis beyond the womb, we would give combined HRT. Now, if you had your womb taken out and you had extensive endometriosis, but your ovaries were taken out, so this is where we then switch off your ovaries. So we're trying to stop any endometriosis deposits building, and we're trying to shrink any endometriosis deposits that are already there. Now, the evidence says that when you have your ovaries taken out, if you've got endometriosis, the likeliness is that HRT does not trigger or flare up endometriosis. But there's not enough data. And for that reason, it is advised to give combined, so with progesterone, even if your womb's been taken out and your ovaries been taken out, combined HRT up until the natural age of menopause at least. Okay, so the first scenario, anyone with a womb must have progesterone. Anyone, if you've taken your womb taken out but you've got extensive endometriosis, you're going to have combined with progesterone. Anyone with their womb taken out and their ovaries taken out, you would still have combined, so with progesterone up until the natural age of menopause if you have extensive endometriosis. Now, if you don't have extensive endometriosis, that is, it has just been found and it's just restricted. Now, only if you can be confident that is the case, that it is restricted to the womb, so that could be your adenomyosis, so within the womb muscle layers or local, and you have your womb taken out, everything taken out, your womb and your cervix, only then can you say you do not need to have progesterone. But you have to be confident that there is no endometriosis anywhere else. What happens if your cervix has been left behind? Now, you can see the area from the womb lining to the cervix is a very, very thin line, literally. So again, only if you can be confident that your womb lining has been completely removed with your cervix remaining in, can you say that you don't need progesterone. If there is any chance of any womb lining deposit being left in, or if we can't be confident that your cervix has been left in without there being any endometrium left, this is in endometriosis or without endometriosis, we would do a progesterone challenge. So why can we do a progesterone challenge? Because the cervix has still got an outlet to the vagina. If we gave you progesterones for 3 months, took the progesterone away, and you had a withdrawal bleed, that indicates there is still womb lining somewhere in that area. For that reason, you would then continue to have progesterone for as long as you are taking HRT. Okay, so this is for people who have had their womb taken out but their cervix is left in, to be confident there is no womb lining left because it's a very thin line between the two. We would then give you a 3-month progesterone challenge. If you bled, you would continue taking progesterone while you're having HRT. If you didn't bleed, then that's a sign you don't have any womb lining tissue left and you don't need progesterone. Okay? If you have any womb left, but no extensive disease, you would still need progesterone because, as I've said, any womb lining, your womb is still there, you would need progesterone to protect your womb lining from womb cancer. Okay, so that is both extensive disease and no extensive disease we have covered. If you have gone through natural menopause and you have had everything taken out, then the same would be applied as what I've just talking about. So that is as if your womb has been taken out. What would you do? That would depend on extensive disease versus non-extensive disease. If you've gone through natural menopause and your womb has been taken out, everything's been taken out, and you have very restricted endometriosis to your womb, then you could have estrogen only HRT. Okay? Now, if you are forced into menopause, what happens then? So you could either be forced into menopause by having, for example, GnRH, so gonadotropin releasing hormones, and what they do is they put you into a medical menopause. You will automatically then be offered, or should be offered, HRT or tibolone, which is a synthetic steroid which has androgen, progestogen and estrogen properties to replace the fact that you've been thrown into menopause. So prior to menopause, if you're thrown into menopause because you've got endometriosis to help with your symptoms, you should then have HRT or tibolone. The reason being not only because you will then probably get menopause symptoms, but also to protect your bones, because you are thrown into menopause at an early age, and it's to protect your heart and your bones and for brain cognition. If you are thrown into menopause because your ovaries have been removed, again, you should be offered HRT because of the fact you're thrown into menopause. Now, the other thing to note if you're thrown into menopause, i.e. you go through an early menopause, is that you're more likely to need higher doses of estrogen, and a lot of women tend to need testosterone as well. And that's really important to know, because obviously people worry, if I've got endometriosis, is it going to flare up my endometriosis? So this is where we need a careful balance, but to understand that younger women do tend to need higher doses of HRT, okay? If you have not yet gone through menopause, so this is the next scenario, i.e. you're premenopausal or perimenopausal, this is what I was saying to you at the beginning. HRT may not always be the answer. It depends on your symptoms and your quality of life. If your heavy periods are the only symptom that you're getting, you may want to tailor your HRT or tailor treatment to that. So that might be having contraceptive. So hormonal contraception often helps with those symptoms. You may just be okay with having a hormonal coil if, again, heavy painful periods are your only symptom. And this is why I'm saying this is so complex and very much dependent on your individual symptoms, okay? And then the final scenario we were talking about is fertility. If fertility is at the forefront of your mind, then having hormonal medications obviously can stop ovulation. You don't want to do that. So the options would be non-hormonal treatments, or you can actually have HRT, and I've had many patients get pregnant if you use body identical HRT. Again, similarly applies to any type of menopause symptom relief and treatment, but with endometriosis in particular, again, it's balancing that, triggering and flaring up your endometriosis versus making sure your symptom of menopause symptoms are under control, but also if you're trying to get pregnant, so you can have body identical HRT. That's really complex and I really appreciate that, but I hope that did at least summarize at what point you have what types of HRT. And if anything, my take home is you absolutely can have HRT. It's about your quality of life, but it's about balancing it all and really taking a good history from you and talking through what the different options are. I hope that helps.